Hi everyone, and welcome back to Making Dads Summit. We've been just talking about men all week long and the importance of bringing awareness to men's health and men's infertility or fertility issues. And once again, I'm joined with my co-host Sara Naab from Don't Cook Your Balls and Dr. Eisenberg.
Thanks for setting this up. Thanks for having me.
Let's start with that deer in the headlight moment. You're trying to have a baby, it's not going so well, you finally get in there, you finally get that semen analysis done, and that dreaded moment happens when you look at it and there's nothing there, and it's probably one of the most terrifying moments of a man's life to just see that paper. What's going on?
Yeah, and it's very devastating to have to give that news to men. But I think one thing that I always try and let them know is it's not that uncommon. So about 1% of all men in the world, in this country, have no sperm. So one sounds small, but that's actually a lot of men. That's millions of men. So I think that's important to know that they're not alone. And the other thing that's important to know is there's a lot that we can do. So just because there's no sperm in the ejaculate now doesn't mean that in the future there won't be. There's a lot of treatment options that we can offer that hopefully will improve it. So the first thing that we look at when we talk about azoospermia, or no sperm in the ejaculate, is why. And so there's two kind of broad classifications. One is there could be a blockage in the system, so sperm is being produced, it just can't get out. The other possibility is there's a production issue. And so production is either absent, which occurs unfortunately sometimes, but oftentimes what also happens is there's just kind of limited production. And it actually takes sort of a threshold amount of production to occur so that the sperm can actually get out into the ejaculate. So there may be some production in the testicle, but just not enough so that it actually makes it all the way out into the semen. So the first thing we want to do is try and figure out which of those is going on, and then once we have a handle on that, we can talk about some treatment options. So if it's a blockage, we can hopefully try and correct it so that we can get sperm back in the ejaculate, and so then they can use that just to have sex and have a baby. But other times, if it is a production issue, figure out why production is limited. Maybe there's an exposure in the past. We just need to give a little more time for things to recover. Maybe there's some anatomic reason. So there's actually an association between varicoceles.
Varicoceles, what are they?
Good question. So basically, they're dilated veins in the scrotum. So testicles are outside the body because they need to be a little cooler. And so anything that warms them up can potentially be a problem. And in some men, there's dilated veins in the scrotum. And that's thought to impair normal temperature regulation. And there's some other theories as to why potentially they can cause issues. Increased pressures in the testicle, not being as efficient in kind of carrying away sort of byproducts of metabolism. Those are all some possibilities, but they're actually fairly common. About 15% of all men have them. And they cause issues maybe about 20 to 25% of the time. So the issues they cause are really kind of threefold. There's kind of three main reasons that we would deal with them. Number one, sometimes they can cause pain. As blood sort of distends the vein, sometimes there can be kind of an ache associated with that, and so some men feel that. Sometimes they can cause shrinkage of the testicle. So that just suggests kind of some problems with the health of the testicle, so that's another reason that we fix them sometimes. And the other thing, obviously very relevant to our conversation today, is they can impair testicular function. And the testicle does two things. It makes testosterone, but it also makes sperm. And so sometimes if there's lower sperm counts, it can be associated with the varicocele. And so to that end, while 15% of all men have varicoceles, if you look at men that are trying to have children and are unsuccessful, it's probably about 40%. So it's a little more prevalent in the infertile population. And so because of that, there's this association that's been identified, and that's potentially an actionable item that can be corrected and hopefully improve the chances for men to conceive.
So, Doctor, I have a question. So,
yeah.
And I don't know how to articulate this in a way that it's, so everybody has a sense of normal about their body, right?
Yes.
And part of what I've heard from clients is that they didn't realize that this was an issue. They thought that was normal for them, the amount of heat that is, might be generated by, is that true, generated by having this, excess pool of blood, if that's how you say it? Or I just wanted to address, how do you know that you would have this if what you feel is your normal?
Right, no, that's a great question. I mean, usually they come about puberty, and that's probably about the time that most boys or men start to become kind of familiar with themselves, especially down there. So I think that some people probably, if they are struggling with fertility, may have a little bit more appreciation, doing some research online or in textbooks, things like that. Or if they see providers, they may have a sense. But I think you point out a very, really relevant point that, a lot of times it's not something that you can easily diagnose. Usually it doesn't cause any symptoms. Things that you would obviously feel. If you have an ache down there, maybe you'd be more likely to be concerned about something and, do a little research about it. But you're not going to feel if your sperm count's a little bit lower. That's not something you would notice. You probably wouldn't necessarily notice if one testicle is a tiny bit smaller than the other. So a lot of times it is asymptomatic, and if it's something that you've had for a long, long time, you may not know that it's an issue. But I think that usually in this country, it's usually brought to the attention because either it's found at sort of a screening physical, either by a pediatrician or a primary care provider for adults, or at the time of an evaluation for fertility as well. It's commonly seen.
So you said that the testicle has two functions. It makes sperm and it makes testosterone. Is there cases where a varicocele will impact testosterone production?
Yeah, I think that, even with sperm production, I think it's always difficult to say whether or not the culprit is the varicocele, because there's a wide range of normal for sperm production and for testosterone production. But there's certainly been correlations between having varicoceles having a little lower testosterone production, and then even if there's some studies that show that after a varicocele is fixed, testosterone production will increase. So it is another added benefit that we do get after we fix varicoceles. But it's not, I think, not sort of a primary indication to repair a varicocele just for low testosterone.
So, Doctor, I have a question. Of course, you had such an informative talk last year during the summit, and the phrase that I use a lot that came out of your mouth was "men wait till they're shot to get checked out and bleeding. If that's the only reason why they'll take initiative." Mm-hmm. And so, we've been talking about the gap of the pediatrician when an adolescent, how do you say it, ends their time at the pediatrician, and before they go to a primary care, there's a gap. And so, do you have any recommendations for men about when they should be seen, or what is the gap, or what is the time frame for that, even though there's great resistance maybe?
Yeah, I mean, I think it's a really good point, kind of a fundamental question of why, there's kind of health disparities between men and women. The mortality rate is higher in men, and this has been posited as one possibility for that, is just lack of sort of healthcare maintenance. Women it's sort of as part of it that they're going to go see their doctor. Obviously screening recommendations for cervical cancer and things like that have changed a little bit, but they're used to going to the doctor for, regular annual screening, and it's not really built in for men until they get, much older, like 50 or so. So there is this whole kind of, this whole period of time, this kind of reproductive age period between 20 to 50, where a lot of men don't seek care unless there's a problem, unless they break a bone or, there's some other issues. So I do think, though, it's very important for men just to seek care. If everything is, if you feel great, I think that's good, but there can be lots of underlying issues that are going to manifest later on. I think the new pediatric recommendations are actually to consider checking cholesterol very early in life. I think around the age of 10. So, if that's a recommendation for children, I think it makes sense that, similarly for men or for anybody, you can have your cholesterol checked, have your blood pressure checked, just to make sure there's not an issue. And early on, I think, you could probably do a lot of diet lifestyle changes that may not be as available later on if things have been, progressing for some time. So I think there's really a window of opportunity before health issues arise, just to maintain. So that's always something that I talk to all my patients about.
So this is where this is my question, and Sara, of course, being the mom of boys also, my son is turning 16 and is driving, and I just went for my annual mammogram. Yeah. And in the conversation with him, I talked about self-care, self-checking, and Sara has to listen to this again. She's been listening to me talk about this. but I said to him, you know, it's very important for you to start self-checking. You know, there's so many literature out there about breast care and, you know, annual, you know, breast exam, self-breast exam. So going back to what you said, that a lot of this, you know, a varicocele starts in puberty, right? So you have this young adolescent male who's just really finding out about himself and his sexuality, right? And so what would be, you know, like the pamphlet for breast exams? You know, what should any man do, you know, for an exam?
Yeah, that's a good question. I think that if there's anything that you feel that's concerning, I think you should always bring it to your doctor's attention. You know, I've taught some men general anatomy because they come in with a finding that turns out to be perfectly normal. But certainly if you feel a change, I also think that's important. Now, testicular self-exams, you know, I think that they do have a place, but they are somewhat controversial. So some organizations actually think that they don't help just because testis cancer is so rare. That you tend to find, you know, you sort of create more anxiety than you'd actually benefit. But it's something that I definitely talk to men about that do come in with any concerns down there, to let them know that, you know, no one knows their body better than them. So if they feel any change, definitely come back to see me, and we'll see what we can do.
Well, this is why too, and it's one of my clients brought this up, and it's I know I'm talking about this, and I don't have a penis, but you know, the couple didn't know he had a varicocele. He had his varicocele surgery, and then he was brave enough to say, I didn't realize how when my testicle was in shorts or in boxers or in briefs was, you know, sticking to the side of my leg. It was because, you know, after the surgery he didn't have that, and that was normal for him, you know, because he thought. So I hope the direction of the conversation or questioning is just trying to answer that. So I know that if other clients are watching this, that you don't really know, but the most important thing is to, if you notice a change, to go to the doctor, seek help, or seek advice, or seek an exam, right? Right,
and I think, yeah, I think that's a really good point. You know, obviously I've done several, you know, general exams in my career, and a lot of practitioners have done as well, but, you know, most people that aren't in the healthcare field will not have done that, so I think they don't know normal. So the other thing that you can just establish the relationship with your primary doctors. They'll look you over from head to toe, you know, and see if everything looks normal or if there's anything that they should keep an eye on a little bit closer. So I think that's important.
Okay. So coming back to the varicocele, you know, a lot of couples are faced with, all right, we have we get a semen analysis, we find out there's some abnormalities, either some motility issues or some morphology or some count issues, and now we've done an exam, we find that there is a varicocele involved, and now what are the next steps or the next things for them to be thinking about in terms of their game plan?
Yeah, well, that's a great question, and I get that all the time. I think, you know, the question is what to do next. And I think it's important to know that there's no absolute right answer. I think it's just what feels right for you. So I think there's a lot of pathways, you know, to get to a child. So I think that, you know, I talk about all the options, and certainly varicocele repair is one option. You know, we talk about the timing of sperm production. So it probably takes about 2 to 3 months to make a sperm. So whether we do surgery to fix a varicocele, some men have conditions that we need to give medicine for, so we're going to do that. You know, if they're going to change some lifestyle habits that may have some benefits, it's going to take a little while to manifest. It'll take, you know, 2 to 3 months. So just so they're kind of aware of that time frame when they're thinking about things. So, you know, reproduction is a team sport. So we obviously also want to see what's going on with his wife or partner and see if there's any issues there that may kind of dictate one line of treatment or another. You know, and the other treatments would be obviously for varicocele. We're hoping for, you know, just being able to have just intercourse, timed intercourse, just regular intercourse to have a child. There are also some higher level care, like intrauterine insemination, where we take sperm, put it inside the wife's uterus when she's ovulating, or even in vitro fertilization, where we mix sperm and eggs together in a dish. So just trying to find out together, give them all the options, let them know the benefits, the risks of all of these choices, and hopefully they can come with sort of the right decision for them. You know, sometimes what we do, you know, if they are kind of in a hurry, because a lot of times, unfortunately, male evaluation tends to be bypassed early on in an evaluation because men, I think, don't really realize they could be the cause of infertility, and there's sort of this perception that it's usually the woman's, that's usually, kind of a female cause. But it turns out about 50% of the causes are male factor. But, if you look at couples in this country, probably about 20–25% of the time, the male's never evaluated. So it turns out that when he is, it's probably a little later on. And so if a lot of time has passed, couples may really want to kind of move forward with some of these more aggressive technologies, which I think is fine. But if we're thinking about, this is their first child, maybe for their second child, it may make sense to start to do some things now to optimize everything. So when they're trying for their second child, they're in kind of a better place. So I think, even if they want to do maybe inseminations or IVF for the first child, hopefully if we fix everything, optimize sperm production for him, by the time they're ready for their second child in 1, 2, 3 years, things will be a little bit better.
So are you talking about a non-surgical approach to, I don't want to say addressing the varicocele?
Well, there's two, I guess when I spoke about medicine, I wasn't speaking specifically about varicocele, but for varicocele, there's two main options for treatment. So one is surgical, and that's
okay.
Go in and actually tie off the veins. There's also a radiologic procedure called embolization, where glue or other agents are injected inside the dilated veins to basically clot them off.
Wow, okay. And so that would, of course, have to, if you didn't, I didn't realize about the second one. So that would also go in tandem with creating your plan.
Right. We're thinking about how to treat it. Yeah, so for the surgical treatment, it's an outpatient procedure. It usually takes probably about an hour or so per side. Typically, incisions now are made very small. They're about an inch or so. We use a microscope so we can precisely see all the veins in the area and also not injure other structures that we don't want to injure, like the arteries, which are bringing blood to the testicle, which obviously we want to preserve, the vas deferens, which brings sperm back, which we obviously want to preserve. So there's some advantages to the microscope so we can see more veins and protect more structures. So it's an outpatient procedure. Usually men recover over a few days. No exercise for a week is my ask, and then they can let pain be their guide at that point. The embolization is sort of a similar time frame and recovery. I think it kind of depends on local expertise, which is done. The literature suggests that there may be a slightly higher incidence of recurrence, so the veins coming back with the embolization, and that's because the embolization targets one set of veins that drain the testicle, whereas the surgery can kind of get some of the accessory pathways as well. So there's kind of theoretical advantages, and it is borne out a little bit in the literature that there's a lower recurrence rate. So I think for that reason, a lot of people do favor surgery for the initial presentation, but if they do come back, which sometimes they do, embolization, I think, is reasonable for recurrences.
So, Doctor, we actually had a question that we were hoping that you would address about varicocele.
Okay.
And I think it's the perfect time because you're giving the options of corrections.
Okay.
So it would be, let me find it. After having surgery for varicocele, how long would it be to see a change or different test results? And what do you do if there's no improvement?
Yeah, this is a great question, and this obviously comes up every time we talk about varicocele treatment. So we see improvements probably 60 to 70% of the time. And again, the time frame for sperm production is 2 to 3 months. So usually we start to check sperm counts probably about 3 or 4 months afterwards. So sometimes we start to see improvements as quick as that, but sometimes it can take a little bit longer. The varicoceles they're kind of chronic insults, so they've been there for a long time, injuring the testicle, and so it can take a little while for the testicle to recover. So there is some recovery that I've seen in men at 6 months, 9 months, even up to a year afterwards. But again, it improves things 60 to 70% of the time. So there is a small population of men who don't benefit from varicocele. Again, they cause a problem 20 to 25% of the time. So there are a lot of varicoceles that, for whatever reason that we don't understand, aren't the issue. And so even if we fix it, there's some other underlying problems that are still kind of keeping sperm counts a little bit low. So we do see that sometimes as well.
So does that go hand in hand with a recheck for testosterone levels after you have the surgery?
Yeah, the way that I follow them, absolutely. I check sperm count, certainly. And if there was any kind of issues with testosterone or some of the other hormones kind of involved in that axis, I'll check those again during follow-up as well to see where we stand.
Okay.
Is there anything else that people can do in that recovery period to help heal the testicle?
Well, I think, we look very comprehensively at sort of lifestyle factors that can impact testicular function and sperm production. So we'd really try and optimize things. And I think I always start by saying anything that's good for the heart is good for fertility. So we talk about good diet, exercise, maintaining good body weight, stopping smoking for some of the men that smoke. I think that's very important as well. And then talk about some of these external heat sources that some men do. Laptops in the lap, and as quick as just 20 minutes, it can actually, the laptop in the lap can actually warm the scrotum up about 1 degree, which is enough to impair spermatogenesis or sperm production. So we talk about stopping that, making sure they're not doing hot tubs, saunas, hot yoga. Those sorts of things can all be detrimental. So we kind of look at all these individual factors and hopefully all together do some improvement. The other thing that there's reasonable data for is antioxidant therapy. So a lot have been looked at: vitamin E, vitamin C, L-carnitine, zinc, coenzyme Q. I oftentimes recommend a multivitamin, which will have most of what you need. I think too much of anything can be bad. But there are some products on the market as well that I think are fine. So some men that are on them, we keep them on them. We keep them on it. I think they do a good job. So those are kind of the main strategies that we use.
That's so important, because that was another question too about antioxidants.
Yeah.
And once again, the landscaper guys are here, but we can edit this out. But the question I'm going to ask you about the antioxidants, but
okay.
The question actually, doctor, was: are there any nutritional steps to take, our supplements, to overcome anti-sperm? And what about antioxidants?
Yeah, so I think that there is good data that antioxidants help. And again, there's a lot of antioxidants that are on the market now. And I think that, I don't have an affiliation with any particular brand. I think some are good. And I think if men want to take those specific blends, I think that's fine. The specific ingredients that I think have been studied reasonably well are vitamin E, vitamin C, L-carnitine, zinc, coenzyme Q is another one, and I think combinations of those make a lot of sense. Most of those are going to be in multivitamins, so I think that's fine to take. The other thing that I also talk to men about is trying to supplement their diet with foods that are rich in antioxidants. So dark berries, blueberries, blackberries, things like that can also help. Is sort of other ways to get those antioxidants.
That's so important because of the subtle little changes and how important. Also, after surgery, if you make the subtle dietary changes, is there any studies that correlate with the subtle dietary changes and recovery?
Oh, that's a good question. So far most of the data is looking kind of at a single point in time. So it takes men looking at their sperm count and looking at their diet now. I think changes in diet have not really been studied as well, but we sort of make some inferences. If men that are eating less healthy, more processed foods, higher fat foods have lower sperm counts, whereas men that don't have that same diet have higher sperm counts, it makes sense that there may be some relationship there. And I think making those recommendations I feel good about. Hopefully it'll help their fertility, absolutely. But there is certainly good data that it's going to help their health. It'll help longevity, help them feel better, help their vascular health, their heart health. So I feel very confident that when I'm making these recommendations, I think there's reasonable evidence that it'll help sperm production and fertility, but it can certainly help their overall health.
Great, thank you so much.
Mm-hmm.
I think one point that we talked about that is really important to circle back on just shortly is this idea that men should get evaluated early in the fertility journey because their options are more open there are more options when you do this early on, and you have more time, because it takes time to heal the body. It takes time to heal her body, and it takes time to heal his body if there's something going on. So what would be your recommendations for a couple that's just starting out, or you know, a couple that's thinking about starting their family? When should he be thinking about an evaluation, and you know, what should he be doing on his side in the early stages?
Well, I think that's a great question. You know, so the definition of infertility is unable to conceive after a year. So I think most people would just recommend trying at least a year to get pregnant, and if you don't, then you can come see you know, a healthcare provider. You know, if you look at couples in their peak fertility, and that would be probably late teens, early 20s, the chance of getting pregnant every month is not 100%. It's much lower. It's probably 15, 20, 25%. So it can take several cycles for couples to conceive. And, you know, obviously that's peak fertility. Nowadays we tend to wait a little bit longer before we're trying to have kids. So just to be aware that sometimes it can take a little while. It's not a, you know, perfectly efficient system. But I think if there is any concern, you know, that the man has, he's had some prior health issues, he's been undergone some, you know, some kind of treatments, maybe had cancer in the past or something like that, something that maybe would put him at higher risk for fertility concerns, then absolutely he should see somebody, I think, very early on. I would say he shouldn't necessarily wait the full year. But as you're kind of going through this first, you know, the first year, first trying to conceive, I think it's important to know these kind of factors that would impact fertility. And I think that's when we kind of go back to this, you know, the health model of, you know, just kind of taking care of yourself. You know, everything in moderation. So if you drink a lot, trying to cut back a little bit, making sure you exercise, maintaining a good body weight, being very kind of conscious in terms of what you eat. I think each of those individually is probably not going to make a huge difference to sperm count, but I think together they probably can. So I think that, you know, taking that kind of very holistic approach, I think, makes a lot of sense early on.
So, Doctor, just to circle back one more, that's so important what you said. I thank you again for bringing that up. But is a varicocele something that you're born with, or is it through a trauma?
It's not associated with trauma, I think, in general. Yeah, we think it is congenital, and actually there is some, you know, it can be heritable too. So if you look at, you know, some families, it does tend to run in families, fathers, sons, you know, brothers can have them together. So a lot of times when I see men, I will ask them if they have, you know, a sibling that should potentially be evaluated, because the incidence can be as high as 50%. So it is, you know, there are some genetic components to it, absolutely. There may be some other factors that are not totally understood. There is some correlation thought to be with body mass index, you know, kind of overall body size. But in general, I think the kind of largest factor that we think about is probably genetic at this point.
What's the workup like? What are some things that some, you know, I think doctors, as we've talked about throughout the week, men aren't very used to going into the doctor, and that, you know, it can be very intimidating. You know, what's going to happen? What's he going to do? What's the workup like?
Yeah, well, nothing should hurt. Basically, that's the first thing I would say. So if we see no sperm in the ejaculate, the first thing you want to do is just check another one, because about at least 20% of the time, if there's no sperm in the first one, we can find some in the second one. And I think if we find sperm, it really changes the scenario dramatically. Even if there's just a few, I think it gives us a lot more options immediately. The other thing that we want to do is check some hormones. So the testicle does two things. It makes sperm, but it also makes testosterone. So we check testosterone and some of the other hormones involved in that pathway, and that'll help us tease out a little bit whether this, again, it's an obstruction problem, a blockage problem, or whether it's a production problem. And then anytime there's very limited sperm or no sperm, the other thing that we look for is some rare genetic diseases. And so this is another blood test, and this just lets us know, again, likely what's going on, because I think it's always important to figure out the why and how correctable it's likely to be. In addition, kind of depending on some of the different test results, there also could be some implications to any kids. So one thing that we commonly test for, or we always should test for, is a Y chromosome deletion. So if we remember from biology, women have two X chromosomes, man has an X and a Y, and on the Y chromosome there's a lot of DNA that's important for sperm production. And so rarely a little piece of this DNA can be lost, and so that would be the reason that sperm production is not optimal or completely absent. And so if a man has this problem with his Y chromosome and he has a son, his son is going to get this same Y chromosome, will have this same problem. So I think that's important to know. You know, I've counseled men with this deletion many times, and I think there's kind of two main answers. You know, some men say, well, when my son is ready to have his own family in 30 years, we will have found a solution to this. So I'm not too concerned about it. Let's proceed with having a baby. But other men would say, well, you know, I know how stressful this has been for me. I don't want my child to go through this. So in that scenario, maybe I'd just rather have daughters. And so I think both of those are options. But I think it's very important to get that information. And so I think that, you know, when we do get this diagnosis, it's important that men are thoroughly evaluated by people that are familiar with, you know, the workup, because I think all these different tests and the kind of implications of all of them are very important. And some of them can be quite complicated. So it's just important that, you know, you have some familiarity with it.
So of the causes of azoospermia, is it more common to be a production or a blockage?
You know, it really varies a little bit on the population that you're seeing, but it's probably about 50-50. You know, in general, you know, the common causes of production issues, a lot of men you can kind of pinpoint it, whether it's some of these genetic causes, which contribute maybe about 10 to 20%. A lot of men have a history of, you know, prior cancer and prior treatments, and so, you know, they have this exposure in the past of chemotherapy or radiation, and that's a clear cause. But a lot of times, even after we do a complete evaluation, there's no clear cause of what the issue is. And then for blockages, again, sometimes we can clearly identify why this occurred. Sometimes there's congenital problems in terms of development. Cystic fibrosis, you know, thickened secretions in the lungs, that's how it, you know, manifests as the disease that we're kind of mostly familiar with the pulmonary manifestations. But it can also thicken secretions, you know, down below as well, and so it could lead to malformation of the vas deferens or some of the other structures in the genital tract that can lead to blockages. But again, sometimes we can't identify a clear cause.
So, Doctor, can we bump back to one of the things that you said, that so you test and then you retest, and
yes.
So does that have to do with the sperm production?
Well, there's just variability in one semen analysis to the other. So there was a study done a number of years ago by the World Health Organization where they followed one man and they checked his sperm count about every week, and you just saw wild fluctuations. So that's just known for, you know, for unclear reasons. There may be lifestyle factors, other seasonal factors that can affect it. But also some laboratories have different experience with checking very, very low sperm count. So when there's really no sperm count on the first kind of gross measure, we do what's called a pellet, and that's where we take the whole ejaculate volume, concentrate it to a very, very tiny amount, so we're really concentrating everything that's there. So if there are a few sperm, it makes it much easier to identify. So you want to make sure that, again, the laboratory also has some familiarity with the condition.
The reason why I'm saying that is because some of my clients have had that experience of getting the call that there's absolutely no sperm, and then to retest again, it's for me, how I explain it, it's like a selfie, right? You're just taking a sperm selfie at that moment, and just like if you go someplace else and take a selfie, it's going to be different.
Right.
And would that be an accurate way of describing it?
Yeah. No, I have seen some men with wild fluctuations. So, you know, testicles are outside the body because they need to be cooler, and so anything that warms things up can be a problem. So I had one man that had a good sperm count, and then all of a sudden it went to 0, and it turns out that he had a really bad flu, really high fevers, and his sperm count went to 0. We gave it a few months, it came back to normal. So I think that, yeah, you know, again, it can be somewhat dynamic, so we want to keep a close eye on it, but do repeat it.
Well, the reason why that's so important is because when you hear that information, your whole system goes into fight or flight, right? Like there's a problem, oh my gosh, especially if you've been trying, and now the gentleman or the man is getting evaluated, and then you get this news. So I'm just trying to, you know, quiet that part of, 0 to 100, that
yeah.
let's just, you know, have another retest because it could be different.
Right, absolutely. And I think that, you know, obviously to hear you have no sperm is devastating. I don't think there's any question about that. But I think it's not hopeless. And it doesn't mean that you're sterile. I think techniques can definitely be done to help you have a biological child. So I think that's very important to hear about as well.
No, that
I think it's also important to talk about second opinions. You know, some people will jump to conclusions. Okay, this is what it is, and now you have these options, and not really taking the time to understand it. And I feel that it is important for someone to listen to the advice and you know, do a second semen analysis, get an underlying diagnosis of what's going on to figure out if they do have options.
Yeah, absolutely. You know, I've given second opinions for patients. I know some of my patients have gone for second opinions to other providers, and I think that's, you know, it's very reasonable just to hear other people, even if they're telling you the same thing. I think it's a, you know, it's a big deal. It's a very important part of life. So I think that you should get as much information as you can.
So can I ask you another question? When you talked about, you know, that the scenario of the dad saying, well, in 30 years it'll be different, right? So I've been around in the fertility, you know, as an industry now for a while, and you know, there's such leading technology about going in and finding. I think, Sarah, what was the word? Pocket full of sperms, or you know, there's other ways to access sperm when you determine you are producing it in case there is a blockage. Is that correct?
Yeah. So what we do now, if we do think there's a production issue, what we do is look inside the testicle to see if there are some limited pockets. And so we found that if we use a microscope, we can identify these kind of little pockets inside the testicle where, you know, some of the components of the testicle are more likely to produce sperm. So they tend to run with blood vessels, tend to be a little bit larger, a little bit thicker, a little darker, and so that can be where sperm is, whereas other parts of the testicle don't have production. So the testicle is very heterogeneous. In other words, if you look kind of at one spot, it doesn't mean that's reflective of what's going on everywhere else. So you just want a very kind of comprehensive view, and the microscope really allows us to do that very systematic way and very safe way, because we can just minimize the amount of tissue that needs to be removed. We can be very kind of efficient in just getting the sperm, but kind of minimizing trauma to the rest of the organ.
That's so important, because you know, getting that news, you know, of the test results, there's just so many options too. You still have choices, and
right.
That, you know, I love that word, pocket full of sperm. You know, I love that.
Yeah.
I know that sometimes obstructive things can be caused by things like infection. Is that how common is it that, you know, an STD or an infection or something like that would block off?
Yeah, I think, yeah, we do see that a lot, and a lot of times men do have a clear history of it. They have something called epididymitis, where there's an inflammation in the scrotum that leads to a lot of pain. Treated with antibiotics, everything calms down. So even though the active infection is gone, there can be still a lot of scar tissue. And, you know, sperm is made in the testicle, and then it matures in this structure called the epididymis, which sits just on top of the testicle. And then from there, sperm goes to the vas deferens and then up into our bodies and eventually out, you know, in the ejaculate. So the epididymis is this very fine tubule, and so if there is this big inflammatory process during an acute infection, whether it be from sexually transmitted disease or other form of infection, even though everything is settled down, the infection is gone, there can still be scar tissue, and these tubules are so delicate, it doesn't take a lot to block them. So I think it's very important when we're talking to men with this diagnosis, again, to get a good history, to find out if there's anything like that that's happened in the past, because if there is a blockage, again, that's a reasonable prognosis. We can definitely get sperm, and hopefully we can actually do surgery to correct it. If we can identify the site of blockage, we can, you know, redo some plumbing, which is what urologists do pretty well, to eventually get sperm to go where it needs to go.
I think the other message there is that I hear from you, which kind of echoes the rest of our week, is that if you do have an infection or you have a problem, get it treated. Because you could be preserving things later on down the line and not have to, you know, go through this trauma and stress of having an azoospermic result and then subsequent surgeries if you just treat it now with your antibiotics and stuff.
Yeah, I think that's an excellent point. Yeah, just don't, if your body's trying to tell you something, don't ignore it. Definitely listen to it. Go to your doctor, get it looked at, and because there could be implications down the road.
Doctor, you have time for one question?
Yes.
Okay, and then we know you have to. So the question is there any hope of reproducing if a man was born without one testicle?
Yeah, That's a good question. So obviously it's it's a paired organ. So one should be enough. Obviously the reason that you were born with, or the reason somebody was born with just one, you have to find out why that was. Because sometimes if there is a problem with development, it can affect the other one as well. But in general, I think that things should probably be okay. I think that would be somebody, early on in the journey, you should get a sperm count. So in other words, I probably may not want to wait a full year. Again, if there is some kind of underlying concern. But one testicle should be enough. We know that men that have lost their testicle to trauma, lost their testicle when one was undescended and during surgery had to be removed, or cancer, those men can still be fathers, and obviously, a lot of times without any assistance at all. Their sperm counts are totally normal. So I think that I would be optimistic if that's the only problem.
There's a follow-up portion to this, and it's the woman of the couple asking this, and it says his parents told him when he was very young he had no chance of having children, and I think that brings us to back to the time within this industry and the changes within it. So can you just address that?
Yeah. Well, I don't know where. I don't want to speak bad about anybody's.
No.
But I don't know where that information came from. So I think before you get that kind of diagnosis, that's, I think, a great point. We talked earlier about second opinions. I think I would definitely go talk to somebody and see what they think, and check a sperm count and see where everything is, because 30 years ago, I think our technology was not where it was today. There's been really revolutions in modern, in modern reproductive medicine, from in vitro fertilization, with intracytoplasmic sperm injection, where we can actually just take one sperm, inject it right into an egg. Those are just marvels, and they really lower the the bar tremendously about how much sperm we need, how much sperm a man needs to become a biologic father. So I think for those reasons we're in a much different place. But again, if a man just has one testicle, that's not necessarily a huge problem. So I think I would just get more information, and I would tell him to to seek a consult with a reproductive urologist or a urologist, or even his primary care doctor, just to sort of a basic evaluation to see kind of where he stands.
And how common is that, doctor?
To be born with one testicle?
Yeah. Is there?
Yeah, I think probably, I would say maybe around 1%, maybe a little bit less.
Okay. I was just trying to help him feel like he's not, he's not alone in this, because. Yeah.
But if you have only one testicle that you can feel, the other testicle could still be up in the body. So I think that you should make sure, again, for health reasons, that has been thoroughly evaluated, because there are some conditions where it's in the body, doesn't come down, but it still is kind of a risk. So it's not something that should just be ignored.
Okay, thank you so much.
Mm-hmm.